Good afternoon, everybody. I'm Julia Hoja. I'm co-founder and CEO of Zana. Me and my team are very excited to organize this webinar today, also to have you here. You'll be hearing a lot about voice biomarkers, and what we'd like to present to you and introduce to you today is a new way of thinking about voice, not just as a means of communication, but also as a biomarker of health. And we'd like to start punctually the webinar. It is my pleasure to start this meeting, this get-together today with an expert, a pioneer, a very close collaborator of Zana, of our team, Dr. Sami Simons. It's really a privilege and a pleasure to have him here today to start the webinar. And after having this dialogue with Sami, who is also, as I mentioned, been one of the people that has worked closely with us in developing the technology, doing clinical studies and publications, and then next bringing it also to the real world, we will give a presentation of the work that we've been doing at Zana, how to use voice as a biomarker of health. And we will also introduce you to the platform that we've developed that facilitates the exploration and discovery of voice biomarkers independent of the medical condition. So I'd like to start right away with the conversation with Sami. And
hi, Julia.
First of all, hi, Sami. Thank you so much for taking the time to be here today. I know that you are very busy, and I'm very respectful every time that you can join us, especially as in an event such as today.
Yeah, lovely being here. Thank you so much for the invitation as well.
Sami, I'd like to start introducing you also to the audience and to the participants of the webinar today. You are an assistant professor in respiratory medicine at Maastricht University in the Netherlands and a consultant in respiratory medicine at the Maastricht University Medical Center, where you had the hybrid COPD specialty service. And at MUMC, you also have the role of the medical director of the pulmonary function, and you lead the Voice Analytics Laboratory, which focuses on developing digital technology for people primarily with COPD. For those that don't know, COPD stands for chronic obstructive pulmonary disease, so a lung disease. And your work has specifically focused on advancing voice vocal biomarkers. Thank you again for being here today. And what I'd like to start with is going back to 2020, now almost 6 years ago, when we started investigating, we started talking about this possibility of using voice also in respiratory diseases. What made you think back then that voice is helpful for medicine, is helpful for healthcare?
Yeah, thank you so much, Julia, for this question. So actually, it was really driven by a clinical observation. But even before 2020, I still remember that my specialty training medical director, that was in 2010 already, she noticed that people with COPD, when they have a flare-up of the disease, so they're deteriorating, that their voice changes. And for you, these were times without any mobile phones, so we had really analog ways of reporting or recording voice, and only statistical methods for analyzing it. So it's already at that time that we thought, well, voice could be a biomarker purely driven by clinical observations. I think in 2020, I met you, Julia, and your team, and I was really amazed by all the work you've done on machine learning and the chatbot, and that combination with the chatbot, because for people, a chatbot is not AI. It's really like a conversation that they have. I think this combination, was gold when we hit that, and I think that's the start of a very good collaboration since then.
Yeah, absolutely. So we've been mentioning already this terminology, voice biomarker. If you had to explain it to one of your patients, or maybe several of those, in one sentence, what would you say? How would you communicate it to them?
So a vocal biomarker is a signal in your voice that tells you whether you are okay or whether you would need help from a doctor or a professional. I think that would be, in a nutshell, how I would explain vocal biomarkers to a patient of mine.
Yeah. So when we bring it to the currently used tools in monitoring respiratory disease in patients that are also chronically ill, what do you see now as the biggest blind spot? And how is this potential of the voice analysis in the scope of the monitoring basically covering that gap and that blind spot in current solutions?
So current systems, I think for the context, the current systems are using questionnaires, are using telephones, are using maybe vital signs, but they are all mostly are reactive. Patients, they pick up the phone or they contact the healthcare system when they have complaints. And the true blind spot is the space before this really clinical event. So we don't know what really happens between their first complaints and when they contact the healthcare provider. And I think the way of prognostication of this exacerbation or this deterioration in health, I suppose that is the true endeavor I think we need to have. So coming from a more reactive care towards a more proactive care, I suppose.
And so these shifting to the proactive and the preventive is what I suppose is also the hope and the potential for changing the care for the patients tomorrow, be it with a voice biomarker-based technology or also other digital tools.
Yeah, I truly agree. So I think it's important for the public also to understand is that for me as a clinician, the current suffering of my patient is preventable suffering. If we would have a tool that would really be helpful for them in their daily life, that would really be very tentative towards their deterioration and proactively help them towards steering towards more like better health, that will be a game changer. Right? Again, reiterating, current care is really still really reactive care at the moment.
Okay. So together, one of the biggest milestone that we have achieved is to realize the Tactica study, a study that in which we, especially your team, recruited and involved patients with both COPD and asthma. First of all, if you can give us your impression of, especially for this respiratory disease, what makes this analysis of voices biomarker as a natural fit? And in addition to that, this was one of the first works and projects in which we together saw how patients were engaged with this tool and with a voice task outside the clinic in their home environment. We were monitoring them for 3 months. What can you share in terms of the learnings with that project, how the patients were reacting, their behavior, their feedback?
Yeah, sure. So first of all, just to provide some context, so the Tactica study was a study we co-developed together with your team, Julia. It was an app patient used at their home daily when they collected voice. And as a ground truth, they also collected data about exacerbations. So we could retrospectively determine whether voice would be able to detect those exacerbations. And for people who are not familiar with the word exacerbation, that's a true deterioration in health, and that's a very important point in their lives of patients with COPD. So you would want to do everything to prevent or to treat that early. So what we were able to do in the Tactica study is to follow these patients for a couple of months, and they could really use the app daily. And whilst the, let's say, adherence and the app interaction was not the main focus, it was really capturing those exacerbations. I think what really surprised me was to see how easy it is for patients to use a chatbot or a voice-based app. We saw adherence rates above 80%, 80%, which is really high. People were telling, yeah, well, this like it is as easy as brushing my teeth. Just they need to say for 10 seconds. So all this, I think it's the the advantage of voice, it's really intuitive. People speak daily. It's for them, it's really easy to speak into a chatbot because they're using WhatsApp already. So I think the easiness and the all, let's say, it really aligns with how they use media or how they use their mobile phones already. I think those two, I think, were really, which made it a success in my view.
Absolutely. And so after the study, we did a thorough exploration of the voice as a tool for predicting and detecting those exacerbations on time, a series of publications also in renowned congresses where you are usually actually also active. We are also now involved in this big DaySil project. I'll be glad if you can also say a couple of words about the project. It involves so many partners to engage COPD patients. And so in the context of that, now that we're doing this work to bring this into real world deployment in the digital care pathway, when you look back, what has been the most challenging part, but also when you look forward, what do you see as the challenge?
I think that's a really difficult question, to be honest. I think so. I think again, we're talking here about a specific disease, so COPD, and I think for everybody to understand what COPD is like, it is a disease which has a large stigma in society. So it's often associated with smoking, which it is most important cause, but it's not the only cause. It's often it afflicts people with a low socioeconomic background who are not, as most of us, digitally savvy. So pioneering or doing research in this type of underprivileged community in our society, I think that's been both a hurdle but also very, very rewarding for me. I think what we now see of the way I've changed now is in my approach towards those patients is and it's not one thing, but I think how we approach them now is differently. And what we see actually is you see a true empowerment of those patients. You've alluded to the DESL. For the audience, the DESL is a very big, large consortium where we are developing a companion for patients with COPD. We had our annual meeting a month ago, and there were people with COPD on the podium expressing how they would think the app would need to work. And for them, because they feel themselves as not, let's say, noteworthy of saying this to, let's say, the professors and all those very wise people, and them expressing themselves and what they want and feeling that they heard. I think that's very important learning and a hurdle we have overcome now. I think that's one of the things when I talk about hurdles, that's one important hurdle in COPD respiratory monitoring.
I understand. And when we project it to the trust and reliability that the doctors then would require to use this technology. So as I mentioned, we are now looking to have this real world deployment with several pilots. So what do you see that the clinicians also are looking forward to see, be it in the voice biomarker technology or any digital tools that help them into delivering care? Where do they need those factors or those instruments to gain more trust, to gain more reliability about adopting them?
Sure. Yeah. So the funny thing is it's a bit of two worlds. When I talk to them and when I ask them how fast, when a patient calls you, how fast do you know when something's wrong? They say within seconds. So voice really resonates to them, and it really, let's say, aligns with their clinical way of reasoning of how they feel. So I think for me, voice is really it's really closely approaches my clinical experience. That said, really deploying this voice-based biomarker in clinical care, it's the concerns are safety. I think a lot of safety for that they have, and also I think a lot of previous monitoring systems have failed in the COPD field, in the respiratory field. So I think a lot of say that way. What about this? Is like only a new tool, a new cool tech. It doesn't really, let's say, help us move forward and help my patient. So these two hurdles about safety and clinical validation, and hurdles about okay, what's different from all the others that I've tried. I think these are the things that's holding us back at the moment. Yeah.
Yeah, I understand. And this is also where we are striving to put this into this real world environment and get as many patients as possible to really validate at scale, because what we've been doing right now, it's mostly also at confined clinical studies, which I believe these scalable and larger validation will also serve the purpose of gaining more trust over time.
And also having, because we are, of course, the pioneers, we believe in this technique, so we tend to see things as positive. So I think deploying this in the real world and seeing it working in the hands of people who might not be that positive, I think that's really helpful for us to understand how this would then actually work. So it's not only patients, but also the healthcare professionals doing this type of work as well.
Absolutely. So when you think about the use of voice as a biomarker beyond respiratory disease, what are some other areas that excite you, where you think there is a lot of potential, or maybe those that have done some initial attempts, but or also other indications or domain where you say, okay, here this could bring a huge value and a shift in how we are delivering care?
Yeah, well, there are a couple of health spaces that are really, really promising, I suppose. So first of all, mental disease. There's been a lot of work performed on dementia and on depression as capturing via voice. The other like really exciting space is cardiology. We know heart failure also affects your breathing and your voice, and I think these are really exciting, and also things I look at how they are proceeding and learn from them. And for me, when we talk about cardiology, I think that is for me both interesting and scary, because my patients also have the combined disease. And what can you do when a patient presents at my department with a combined disease? Is voice capable of differentiating between the respiratory or the cardiac condition? So these like really messy, because patient care is messy. So those messy, muddy patients, you don't know what they have. I think that's the really also exciting. Then again, also the challenge we have these coming years.
Absolutely, yeah, very interesting to hear that. What makes you also truly unique is how you interact with all these different worlds, which we usually perceive as separate. You are involved fully, of course, in the clinical practice. You are involved in designing and leading graduate programs, but also engaging with technology developers and startups such as ours, really at the frontier of the technology with engineers. And then, of course, the patients. And as you also mentioned, all the hurdles and the care, the intuition that is needed. So how do you see your role as a mediator, or maybe putting all these people together? What has been the challenge, and what is the rewarding aspect of it?
So for me, the most rewarding aspect is I'm a curious person. I always want to understand how it works. So I think talking with everybody, and I think for me, what's been really rewarding is that everybody with whom I'm working with, also with you, Julia, is that you have had the patience to explain to me as a clinician and again how this works. And so I think it goes two ways. And what I see myself now, I see my role is shifting a bit. Whereas like 6, 7 years ago, I was really truly a clinician who was going into the field of medtech, and now I know a bit more about medtech, and now I see myself going back, explaining to my fellow pulmonologists, okay, this is what you can expect. So I think my role is shifting a bit, but again, I think most important is that you collaborate and work with all these different partners. This is not a solution you can come up with by your own. There's no singular solution. You really need all the different types of disciplines working together to solve this for our patients.
Yeah. It is, I have to say, it has been absolutely thrilling to witness during all these years and the collaboration together, how your patients, also your desire to learn, to investigate more. And I truly hope that we have even more physicians and doctors in the clinical practice that basically confront and embrace the technology with the care and also with the curiosity that you have. And I personally, also on behalf of my team, thank you for the collaboration, and we look forward to continuing this also, as I mentioned, with all these real-world deployments and see it as a voice, as a signal in the routine of the care. And with that, Sami, I'd really like to thank you, and we will then proceed next with the rest of the agenda for the webinar. Thank you, Sami, indeed. It's been a pleasure. So we already mentioned biomarker a few times. This is coming also from research and science. I'd like to frame it as per the definition of a biomarker. It is an indicator of our biological state and medical condition, but it needs to be measured objectively, accurately, and repeatedly. And traditionally, traditional biomarkers come from blood samples, imaging, or clinical devices. We know that they're very powerful, but most of the time they're invasive, expensive, and difficult to scale. And this is where voice brings this unique and new opportunity. Usually, it is also stated that voice is the new blood. So it is one of the most accessible tools from our body that reflects the individual's physical as well as emotional well-being, and it can be tracked in our everyday devices. So to enable this as a biomarker for healthcare, at Sana, we have developed VOICE-BIOME, a device-agnostic end-to-end platform that helps to transform the voice captured in human interactions and recordings into actionable health insights. So how it works? The main three blocks conceptually, we first have to enable a collection of real-world voice data. What has been our common practice until now is a mobile app on which we can also longitudinally track voices. In this case, in most of the projects, we have given to the patient this app, guiding them into 3 simple exercises. The first one is called the sustained vowel phonation, so they have to say as long as possible. They read a well-balanced text, and also they can have a free speech. So we ask them just to tell us how they're doing, how they're feeling. They also have the opportunity to listen to what they said and also to repeat the task. But beyond the mobile app, an interesting development has been to see the embedding or integrating the speech technology in a medical device. In this case, a partnership with a Cosmos company in Germany that enables measuring vital signs through this in-ear sensor. But the patients can also communicate. Sometimes we call it like Alexa in your ear. And then you can also measure vital signs. This has been a device which was also tested in a home setting for patients with heart failure. But now that we see the rise of voice agents, LLMs, medical scribes, I think we have even much more possibilities to collect this voice, as long as we have good quality recordings from doctor-patient communication, from wearable devices, ambient-assisted living devices, and we'll see even more screenly devices coming up into the markets. After the voice data are collected, in our case through these guided simple tasks, they are safely transmitted to the platform. And this is where our technology, the biggest contribution of our technology is. So what we do, we process these recordings, this audio data, of course, coupled also with a metadata about the patient. And then we extract a multitude of voice features, feeding them then to machine learning models to map to health outcomes, and then to generate assessment score. For example, to generate the probability that the patient will have a risk of a flare-up, the COPD or exacerbation that Sami mentioned, or this acute symptom worsening. But of course, the assessment score can be done and can be mapped to the data that are being ingested. This biggest contribution that we have done implemented in the platform, as I mentioned, is this multitude of voice features which serve as measures, subtle measures of the signals hidden in voice. And they also give us insight in how the function, how the brain and how the body functions, so physiological as well as neurological functions. Beyond the whole infrastructure and the services that we have in the backend, we have developed also a no-code visual interface that enables this end-to-end voice biomarker discovery, and which also we want to showcase some important features to you today. When the analytics is done, when the prediction and the training is done, the results can be sent back either to the patient app or to any services of choice via APIs. For example, in this implementation, in this project, after doing the voice analysis of those tasks, what we show to the patients are, we've selected 4 features: the smoothness in the voice, energy, breathiness, and pitch. And then we also have a way of clarifying what they mean, explaining them to the user, but also doing a tracking of how they change over time. These scores can, of course, also be embedded and integrated into monitoring dashboards, such as, for example, in patient remote monitoring for doctors. In this case, we provide such services to predict the risk that the heart failure patient is getting worse, and then with the potential to avoid hospitalizations. Until now, we have primarily focused on 2 medical conditions. In the respiratory space, as already mentioned in the interaction with Sami, we have been looking at the chronic obstructive pulmonary disease. And in cardiology, we are investigating heart failure with our partner, the University Clinic in Würzburg. So these are 2 diseases that impact over 500 million people, and it's on par with diabetes. And we are lacking the monitoring tools. So voice here is a good indicator. And I'll share with you some of the more interesting results that we've done to use voice as an indicator of health deterioration. So we have done these clinical studies to collect the data, to optimize the technology, validate it. Together with our partners, there has been a series of publications of this work, and then now starting the deployments of pilots in the real world. Our goal, and this is what we're doing progress at the moment, we're focusing is to bring this technology as a medical device certified tool for easy integration into the clinical practice, in this case, into remote patient monitoring. Beyond these conditions, we have been, we now actually are expanding into other domains. We have, in December, we've started a project focused on cardiovascular disease, so expanding beyond heart failure, primarily focusing on gender-specific medicine, and to differentiate between the women and men, and so male and female signs of voice into predicting the risk of a cardiovascular event. Beyond just the monitoring capacity, voice is also a very promising tool as a diagnostic instrument. We have collaboration planned to start in the investigating chronic gynecological disease, which is very highly associated with pain. And so we want to use voice also as a way of screening that disease condition, because it takes a long time, over 10 years, to do that diagnosis, as well as an integration in mapping the voice features into a menstruation and fertility tracking into a reproductive health domain. But beyond that, as Sami also mentioned before, there is a huge potential also in other indications and other areas, especially when it comes to mental and behavioral health. We've seen voice already in neurological disease, but I think there's also the means to go beyond that, as well as in our emotional and affective health insights. So I'd like to give you a short presentation of the results that we have delivered and we have achieved in these two use cases. For COPD, as mentioned, we are primarily looking at the exacerbation, which is also the main driver of hospitalizations in this disease. So this is narrowing of the airways because of the lung incapacities, and this leads to what is called a flare-up or exacerbation that is usually recurring. So what we have done in our Tactica study, we have asthma and COPD patients. For COPD, we have a cohort of 37 patients. They use the app every day to do this recording, and they also report what is their exacerbation state with a certain questionnaire. And then when there is what we call an exacerbation event, this is also confirmed by the doctor, so it was done into the database confirmation and annotation. What we're primarily looking at is this up to 7 days before an event occurs. In clinical vocabulary, this is called prodromal, or the prior phase, the worsening phase before the event. So what we do in the process that we set up is we take the recording, we process them, we do very extensive feature extraction of voice, feed them to a machine learning model. In this case, we are doing the classification between the state that is prior to the event, so this prodromal state, and the stable state of the patient. And the reason is that when a new recording from that patient comes up, we want to basically differentiate if the patient is still in the stable phase or if they are landing into the prior phase, or the phase before the onset of the event. And based on the results, which are also published at the ITG conference, speech communication conference last year, we're able to detect 79% of the events at least 3 days before the onset. So another case, very interesting, very important, is heart failure. We are looking primarily at patients that have this heart problem, the inability of the heart to pump blood, which leads to fluid retention. This affects the speech, and this also leads to what's called cardiac decompensation, also the main cause for hospitalizations of these patients. So we have done a big study involving over 130 patients. So in this analysis, we have a cohort of 131 patients. And we engage them from the moment that they are admitted into the hospital with heart failure, with this decompensated stage, so this fluid retention. And then every day, when we track them when they are discharged from the hospital in what is called a recovered state or compensated state, and then for consecutive 6 months with follow-up points at week 6 and month 6. So we replicate the pipeline, of course, extracting a multitude of features again from these recordings, and then our task here is to differentiate just from voice alone, only from these features, if we're able to classify or basically distinguish if a patient is in the decompensated or in the recovered state. And again, this serves for the longitudinal monitoring, because once we know how to differentiate this state, then we can generate a predictive score that the patient is now leading into decompensation. And again, give it to the monitoring system so that we can avoid hospitalizations. The accuracy, this is another published work, the accuracy that we have achieved in differentiating these states from voice alone is up to 86%. And we have done also very thorough and deep analysis of how are these features impacting. So how are these features changing in the voice between, a sick state and then a recovered state, where you can see parameters such as jitter that look at the stability of the vocal cords, that they are improved after the treatment, or also breathiness features and how they are worse at the admission and then they get better after recompensating. All of these features help us to be embedded in this prediction model that we use for the longitudinal monitoring. Beyond this pre-built and validated biomarker, with our VOICE-BIOME platform, we are also offering the flexibility to discover and explore new ones. And so this is primarily built for teams that basically do not want to worry about engineering pipelines. They want to focus on discovery and validation. So we are now looking at cooperation with different clinical labs that also are coming up with different ideas in different indications. And it's also useful to other life science companies, digital health companies, or anyone exploring voice as a novel biomarker modality, enabling what we truly hope it's a disease-agnostic design and facilitates automation of these processes from collection to training and validation, as well as reproducibility. And streamlining basically the process from start to end and building around this core concept of biomarker protocol as by definition as a blueprint where we can basically track rigorously from the moment how it is collected, processed, measured, and interpreted. So next, I'd like to hand over to be more hands-on to look at the demo. So you can see in this also studio and then this visual interface that we have built, how we can make this possible and how this process is enabled. I'd like to hand it over to Prashad Pompala, who is our machine learning engineer and has been leading the work also in this platform building.
So yeah, at the heart of VOICE-BIOME is our VOICE-BIOME studio. It is a visual workflow orchestration environment where you can run pipelines end to end. So instead of hard coding individual blocks, we offer you templates which you can pick and then run your machine learning problems. So before we jump into this, I would like to show you if you pick such a pipeline and run it, what the results will be. So when you start a machine learning process at Biome Studio, you get all your results organized in a neat place in the analytics dashboard. So currently we have loaded two protocols, the heart failure decompensation and the COPD exacerbation. So today I'd like to share with you some of the results and analysis that we get by running a pipeline at Biome Studio. So this is a process that was run for heart failure decompensation classification that differentiates between decompensation and compensation from admission to discharge data. So if you run a process on Biome Studio, you get such analytics, and you get a profiling block, you get information about data set, about which data set was used to run the process. In the feature extraction section, you get information on what features were extracted, the kind of spectral features, MFCC, glottal, and formats that were extracted. And VOICE-BIOME, rather than being a black box, is also provides you with a rich set of features for analysis, and you can see that in the feature analysis section. So we provide features like time series analysis, heat tables, and box plots. And here, for example, you can see time series data denoting the decompensated state, the compensated state, the 6-week follow-up, and the 6-month follow-up. You can also select individual patients to look into more details about them. You can also click on a data point, for example, the compensated discharge, to see time series analysis and their derivatives. For example, you see the spectrogram of the voice that was used, and also you can play the audio. And for example, in heat tables, you get in the heat tables, the rows are all the features that were extracted. The columns are computed values. And in the heat table, you get p-values of, for example, jitter has a very low p-value. And this denotes that jitter is an important feature that can help classify between heart failure decompensation and compensation, and it is statistically significant. You also get box plots. Box plots denote how well, if you can select jitter, you see that the mean of jitter has changed and the variance has also changed between heart failure decompensation and compensation. So the heat tables show us which features are good, and the box plots kind of show us how each feature varies between compensation and decompensation. And the next stage is also the training stage, where you get all information on how the model was trained. You also have a dedicated section to set up another training request with a different set of parameters and also possibly select different kinds of models. In the ML analysis section, you have a collected list of all the analysis that you had run in this specific pipeline. And when you select a block, you get all the reports about machine learning, like the accuracy scores, the sensitivity, the specificity, and also the ROC curves and hyperparameters all in a single place. And this can be very effective for machine learning engineers as well as clinicians to find out if the features extracted were any good in distinguishing between decompensation and compensation. We also have a models section which stores all the models that were trained in a single place. And we also provide you a dedicated place where you can check if the model performs good. For example, I could select logistic regression and upload in a sample audio file to check if the model is good in distinguishing between heart failure decompensation and compensation. Here, you get prediction results to see the probability of heart failure decompensation with a score. And this can be used to quickly try out models rather than just run pipelines. In the second section, I want to highlight to you how effective and easy it could be. Yeah, maybe we can have questions at the end. So, yeah, so in the second section, I want to highlight how easy it is to set up newer pipelines on VOICE-BIOME Studio. But before we go there, we also have a datasets page. This is a specialized area where you can club together all your datasets coming from different protocols, be it heart failure or COPD or as you wish. So currently, we have loaded two datasets. One is AHF voice for heart failure decompensation, and the other is the Tacticus dataset for COPD exacerbation detection. For example, the AHF voice dataset, we have audio files belonging to patients and also information on their status if they are decompensated and compensated. So once you have loaded your datasets, you go to VOICE-BIOME Studio. To illustrate how easy it can be to set up and run a new pipeline without worrying much about code, I would like to start by using this template, which is for machine learning training, to set up a new process. And I am going to continue an existing process, for which I have also loaded information. So, for example, in the dataset selection, I have loaded the AHF voice dataset. And in the feature extraction phase, I have selected to do my feature extraction on the sustained vowel phonation task, which can provide good insights on respiratory and voice stability. So in the training phase, we define the kind of experiments that we want to run using this process. And at this stage, we have chosen to distinguish between heart failure decompensation and compensation. So those would be the values here. For one of the values, I'm going to give in a compensated discharge date. And the other value that I want to distinguish is the decompensated admission date. So I also want to select the sustained vowel phonation task to perform my experiments on. And since this is a classification task, I've chosen the logistic regression model. I'm going to select global normalization and other machine learning parameters like segmentation and cross-validation. And when I click on complete and start process, it takes me to this nice process management page where you have all your processes listed and also a tab to go to analytics if the process has been run. But this is, yeah. So yeah, as you can see, the process that we just started I started running. So, but this is not limited to heart failure. We want this platform to be as agnostic as possible. So we also have set up a pipeline for COPD exacerbation using exactly the same platform and the same protocols. And if we go to feature analysis, for example, you would see that the features for COPD are widely different. For example, in this graph, we see the blue, which is the baseline, the orange, which is the onset period, the red, which is the period of exacerbation. You can also see this patient has multiple exacerbations. And also, for example, in the ML analysis section, we have trained multiple models already for COPD. And if you'd like to compare how each model performs, you can select models which are good and then also upload an audio file. And this gives a complete list of how each model performs for this audio type. And apart from training, you can also set up prediction pipelines where you connect it to a data set. And whenever a new data comes to the data set, you automatically make a prediction and display the results. So this was about VOICE-BIOME. And as I said also, the idea with VOICE-BIOME is to have it as agnostic to protocols as possible. So we would love for all the participants to maybe try out VOICE-BIOME. And we're also curious to see how voice is effective for other protocols other than COPD or heart failure.
I can start with the first questions, and please enter them in the chat. Feel free to ask other things. The first one is regarding the language. Actually, it is agnostic of the language. What we saw right now are, for example, in heart failure, we have ingested a data set on which patients where are German patients with heart failure, and then they did the recordings in German language. When we have the app, we can also offer it and adapt it to different languages. And then when the pipeline is set and when basically the features are extracted, they are extracted as a whole independent of the language. What is worth noting here is that because every language, of course, will have its own nuances, and people with different languages, for example, also speak fast or slow, this training is exactly done in order to do a personalized and adaptive approach for each patient. So once you develop a model and you train a model, you can retrain it to different cohorts and different populations. And what we saw here is one is German, one is Dutch, and we've also done other feature extraction and predictions also in other languages, in English. Another pilot is also starting up in Portuguese. What happens to the sensitive data, where it is stored, who has access? Very valid, very relevant question. So right now we have a secured cloud solution, so we're not using third-party providers. Armand and Prashant, feel free also to chip in with some feedback here. What I want to emphasize is that we have secured buckets for each and authentication for each organization. So once you set up the platform, you have your own organization. Everything is restricted to your organization, and nobody else sees or has access to the data of this organization. Even when you have an app and the data is collected from the app, it is ingested with high security protocols and privacy only to the buckets that belong to your organization. And another thing is that we are, because we want to market this as a software as a medical device, we have also a certification for quality management and privacy system already in place, which gives us the security to establish processes for the high security. But this is, I don't know, Armand, if you want to add anything else?
Actually, I believe you covered everything very nicely and very in a very compact answer. So basically what you saw in the demo, also the data sets are part of an organization that was created for this specific demo. And the only thing which is the same for all the organizations will be the templating engine. But beside that, when you create biomarker protocols, you are free to create anything And of course, there is some basic structure for the schema that you upload there, but also this is dynamic. So based on key value, you can add any labeling that you want in the data. And all the data and all the data sets, all the processes are isolated from other organizations.
There is a very interesting question from Mark related also to the relevant features for exacerbation classification. I can show you very briefly, if I can. Yeah, if you can show here, I'd like to pick it up from our publication. I'd like to also let you know that this is published also in our website, but gives an overview of the features that are important, where we saw that it play a role into the COPD, primarily when distinguishing this worsening phase from the stable phase. And when looking at the box plots here, we can see, for example, at the prior to onset, we have a lower maximum phonation time. We have a higher jitter and shimmer, indicating this instability and breathiness, lower noise ratio and CPP, also indicating this weaker voice quality and breathiness, as well as more precision in terms of the articulation. And in this case, for example, we have published also in the analysis by distinguishing features that come from the vowel phonation task and also from the reading task. In the reading task, we also see representative features of MFCC, so spectral features that also play a role. So coming back to another question.
I think one of the questions, how long should the subject speak or during the reading and speaking tasks? Maybe even Sami, Dr. Sami, if you want to join.
So while Sami then pitches in, my very quick remark on my part, in the speaking task, we had set actually a 30-second timer, allowing them kind of motivating them to have at least 30 seconds of speaking. Whereas for the reading task, in both the COPD and the heart failure case, we gave them these, the north wind and the sun, a well-balanced text, and they were reading it. Now, how long it takes depends on their disease stage. That's where we see also the speaking time that it changes. Sami, feel free if you want to add anything to that.
No, I think you're correct. So these would be the longer task. The sustained vowel is only 15 seconds max, 10 where you can model. So it's only 10 seconds on average, saying a sustained vowel, which is sufficient enough to do the analysis upon. Importantly, is that you need to take care of the devices that you use. So that's some of the hurdles we overcome. That different devices have different microphones. So this thing you need to take into account as well.
Thank you, Sami. We have a question from Simran in terms of looking at the patients that have comorbidities. Some you also touched upon that, the combined disease, in this case, COPD and heart failure. And the question is if we can differentiate what is causing the exacerbation between the coexisting condition. We are not, with the current data set, we're not able to validate that because the studies were done independently and we don't have a sign that the heart failure patient has also COPD. It's usually the case, but we don't have it indicated in our data set. And these, as I mentioned, are two different cohorts. It is, however, a priority of our work right now. When we set up the pipeline, the protocol, once we also have these labeling that the patient has a COPD and the heart failure, then we can see how the features differentiate. Unfortunately, we don't have that compound data set at the moment in order to really do the exploration and give you a valid answer. But this is part of our ongoing investigation, a very, very relevant one.
Yeah, I do. I think that's the $1 million question, I suppose. When people are in the emergency room, what is the cause? I think that's a struggle we have on a daily basis. That's how would I say, the argument I have on a daily basis with the cardiologist, where to put the patient into the cardiology or the respiratory department. So I suppose it is really, really helpful if there would be a biomarker for that. Current biomarkers, for instance, that BNP levels are not sufficient enough. So I think it's really added there. from a conceptual point of view, but I'm now more towards like my respiratory physiology background. There could be some differences between those two that could be useful, differences in voice actually, that could be useful to distinguish those two. So in theory, yes. In practice, we don't know yet. Yeah.
All right. Another question coming in from Christine. Would like to know how many data sets you suggested in a pilot to be collected and how long the recording should be. In terms of how long the recording, I believe we already touched upon that. Thanks, Christine, for the question regarding how much, what is the scale of the data set suggested for a pilot. So we have seen to have statistically good, significant results, at least even with this small cohort of patients for COPD. However, in order to have even further validation, we have, as in the case, for example, for heart failure study, we've been insisting to have at least 100 patients. But again, this was in the clinical study phase. In the pilot, we hope, at least that's also the wish, to have even a larger scale, so we can validate it even further, also in a real world setting and not in the let's say a little bit more restricted clinical trial environment. And this is also the work we're doing with Sami right now, basically plugging our tool in the digital care pathway of the clinic, of the hospital, and then be able to reach the patient that far, for example, part of the monitoring programs, and to reach as many of them as possible. We have 1 more minute until 5. I'll take one more question from Mark regarding the overlap in the block plots between the prodromal and stable state. So how good are models actually able to distinguish between the stable and prodromal? The accuracy of 75%. So the 79% was the number of events within, so at least 3 days before the onset, that we were able to distinguish that they are actually in the let's say in this worsening, worsening or prodromal phase. And so what is considered correct in terms of exacerbation classification? So yeah, I'm sure Sami will take it. Go on, and I also have my answer to that, but I'd like to hear yours, Sami.
I think correctly. So I think what this shows is that there is no singular voice feature that is good enough to use. I think a lot of effort has been done in the past of finding that sweet spot. It will be a combination. Currently, we have, with the same data set, we are able, when we use like more sophisticated models, we are able to detect exacerbations with around 96% accuracy. So we are indeed, when you combine a lot of data, a lot of different kind of features in voice, you are really able to accurately pinpoint the exacerbation from the stable.
Absolutely, yeah. So I'll take the last question before wrapping up this webinar from Luca. Does the app have, the patient have to use the app daily in order to give useful results, and what is their stickiness or adherence to the daily routine? We've been asking them in these 2 clinical settings to actually to do the voice recordings daily. To be honest, in the Tactica's case with Sami, we even asked them a lot of things, do it various times during the day, and then this exacerbation questionnaire. Surprisingly, the adherence, positively surprising, has been very good, particularly in the COPD case. Also in the heart failure case, we have 1 in 3 patients that use the app every 2 days. However, by looking at the data going forward, we wouldn't really impose them to do this daily. We would expect, of course, to have some good, accurate results, a weekly adherence. But what's also most important is to have a sign when there is a change in the status. So if they've been, let's say, admitted to the hospital, if there was a change in the treatment, because there we know how to really adapt and tweak the algorithm accordingly. But again, the adherence has been really very good for these cohorts, and we know that these are high burden disease. So I know we only showed you only let's say a small part of the iceberg, as we call it. So just to give you a sneak peek on the, let's say, the flexibility and the work we've been doing. We really hope that this is a tool that will be also useful for the research community, for the clinical research labs, also for people working on medtech devices, life science companies working in this area, to really be beyond the usual health parameters, to add voice to their data. This is what we want to make useful and easy. And so this was our very first webinar about this topic and the sneak peek on the platform. We will do more because everything is also being developed very, very fast. And if you have ways of collaborating with us, if you have other data where you want to leverage voice, please feel free to engage with us over email, in LinkedIn, and so we'll be very happy to explore this further. And I'd really like to personally thank the whole team, Lars and Dana and Aldo, just a few of them here that have been working so passionately on this. And I thank you all, and I look forward to our next webinar. Please keep in touch. We'll be happy. Bye.